Hi, and now welcome to Abnormal Psychology. We're going to look at mood disorders. And just as we have been seeing in the theoretical perspectives, there are many possible explanations for mood disorders. So this is also related to treatment approaches. There are many different treatment options, all the way from, of course, psychological into biological. So what we're going to do is we're going to consider some of the leading and more contemporary approaches to treatment of mood disorders. Let's see what we have to produce. Now we're looking at treatment. We're going to start off with looking at psychodynamic treatment of depression, which is traditionally focused on helping the depressed person uncover and work through their ambivalent feelings towards whatever lost object or thing, therefore lessening the anger directed inward. Modern psychodynamic approaches tend to be more direct and briefer. They are moving from years to months, and they tend to focus on the development of more adaptive means of achieving self-worth and resolving interpersonal conflicts. The focus here is on the here and now rather than on the unconscious and childhood experiences. And so looking at other more adaptive ways to resolve some of this conflict in shorter periods of time. If we consider the depressed behavior as learned, then it can be unlearned. So the learning theory approach approaches having focused on helping people with depression increase the frequency of reinforcement in their lives through such means as increasing the rates of pleasant activities in which they participate and assisting them in developing relaxation strategies or how to develop self-change plans for more effective social skills and increase their ability to obtain social reinforcement from others. Cognitive therapists, well, they're helping depressed people identify correct and distorted thoughts. So they work with diaries and charts, identify the dysfunctional thought, and replace it and learn with more adaptive behaviors. So the focus is on learning one's own dysfunctional thinking and to develop more adaptive behaviors. This will often use thought diaries and help clients to increase self-awareness and to better manage their adaptive choices. Moving to the biological approaches, we'll focus on the use of antidepressive drugs in biological treatment, such as electroconvulsive therapy, also known as ECT. Antidepressant drugs appear to increase the levels of neurotransmitters in the brain. They use TCA, or tricyclic antidepressant, MAO, monoamine oxidase inhibitor, or SSRI, selective serotonin reuptake inhibitors. And alternatively, with bipolar, it's common to be treated with lithium. It's effective in stabilizing moods and reducing depressed and manic episodes. Now people, some will be using, and it's despite the controversy, ECT. It's a treatment of choice for very severe depression. The person is anesthetized and given muscle relaxing drugs, and they are given a brief, less than a second, shock directly to the brain. And this results in a brief seizure lasting several minutes. Now the treatment usually is administered once every other day for 6 to 10 treatments. The side effects can include short-term memory loss and confusion, which usually disappear within 2 weeks. It's quite successful. About 50 to 70% of the people who don't respond to medication do respond to ECT. Now, of course, an unfortunate side effect of mood disorders for many people, particularly around depression, is suicide. Now, suicide is one of the leading causes of death for both men and women from adolescence to middle age. Mood disorders are often linked to suicide. Although women are more likely to attempt suicide than men, more men actually succeed, probably because they select more lethal methods. The elderly, not the young, are more likely to commit suicide, and the rate of suicide among the elderly appears to be increasing. So if we consider who commits suicide, well, 28% of 85 to 89-year-olds commit suicide, and 24% of 15 to 24-year-olds, and 16% of 25 to 44-year-olds. That's a large number. And the reason, not the reason, but you can expect the numbers to increase in the elderly because there's more people getting to that range. And oftentimes, because they're living a lot older than people used to, some of their peers die before they do, and they're left without the social connections, which seem to be very important for why people can live long times and be successful. The theoretical perspectives about suicide, well, people who have attempted suicide are often depressed, but they're generally in touch with reality. So if we consider the psychodynamic classical perspective using Freud, well, that is a representation of inward directed anger, and turning that anger towards themselves rather than what they're angry about. So they internalize their anger, and that produces the response that Freud would explain. Whereas more modern sociologist Emil Durkheim, he introduced a concept called anomie. And anomie means the feelings of alienation and disconnectedness for others. That when someone gets into a position where, because of depression or this anomie, this disconnect that they feel from other people, they're more likely to commit suicide. And it fits the current modern view of social cultural view today. The distance we travel for school, for work, we live in bigger cities, it tends to create less connectedness. Now, learning theory, they will look at the possible reinforcing effects of threats and attempts to the effects on stress. They may, however, people who are depressed may lack effective problem-solving skills and see no real other way to deal with some of the stress in their lives other than through suicide. And so relearning and being able to educate alternatives would be a bigger help there. Cognitive social, well, part of the belief that suicide is an acceptable option or acceptable way to resolve problems once and for all, rather than a bit at a time. So there tend to be there tends to be more social reinforcement from examples that they see of other people who have committed suicide. They seem to think that that solved the problem for them. It will solve the problem for me. Now, there's a term that's used that's called social contagion, that sometimes, particularly for young people, is that when one person commits suicide, in some communities you may see others do the same. They see it as courageous or heroic or solving a problem finally. And then lastly is biological. There's some research that's suggesting that neurotransmitters, serotonin, the deficit in that particular neurotransmitter appears to be common to those who are depressed or attempt suicide. So they think that there is some link on the neurotransmitters, but they don't know exactly how much. So what can we do? Well, probably we shouldn't help other people too much. It should be done by professionals. But if there's things that we can do, draw the person out. Ask them questions. Ask them to talk. Be a listener. Be sympathetic. I would avoid using the word understand. Chances are you don't understand, and it's better not to pretend that you do. It's better just to be sympathetic and listen. Suggest that other means other than suicide can be discovered, and that you will help them find other means. Inquire as to how the person expects to commit suicide. Sometimes bringing things to light brings the reality of what they're planning to light, and they're able to then come up with alternatives. Don't degrade the individual. Don't say anything like, that's crazy talk. Whoops, there we go, get caught up here. That's crazy talk, or, you shouldn't think that way. Only crazy people think that way. That's not where you should be going with this. But more importantly, and probably the most important thing you can do, is propose to the person that you will accompany them to see a professional right away. All right? I hope this has been helpful. That's the third of 3 videos on mood disorders. We have done that one, and we'll move on to week 6 in a new chapter. All right, everybody. Good luck, and I hope you have a good day. Bye now.